My name is Ed Tyrrell. I am a GP and clinical assistant professor at the University of Nottingham. And I'm going to talk to you about a paper recently published in Education for Primary Care called Comparison of the Effectiveness of Exclusively Facilitated Clinical Teaching as an Alternative to Traditional Practice-Based Primary Care Placements. As you can tell from the title, it's a GP placement for medical students, but we think there's potential application here to education across a variety of different healthcare students. The problem this relates to is one of placement capacity issues, which we think is fairly universal. And certainly within the last couple of years, this has been particularly exacerbated by COVID and its effects. And our situation in Nottingham at the time we wanted to deliver this was that we needed to deliver a short primary care placement for third-year medical students without any time in general practice, basically because of the severity of the placement capacity issues we faced at the time. It is worth just very briefly saying something about the sort of comparatively junior nature of these students as third years. So in the Nottingham course, they would have done roughly 2 weeks worth of clinical time spread across their first 2 years, which is primarily classroom-based. And just immediately after this particular module, they were about to start their full clinical phase. What we did when we, concluded that we needed to deliver this as an exclusively facilitated teaching model was we used principles of blended learning, flipped classroom methodologies, e-learning and simulation, alongside our own faculty experiences of virtual clinical training, to design a course that delivered the learning outcomes for this short, it was only 1 week, primary care attachment. And what we particularly wanted to make sure was that this was GP facilitated teaching, even though the students weren't going to be able to be physically in a GP practice. The learning outcomes for this module, which were obviously already set before this, were focused on consultation skills, diagnostic reasoning, and students understanding the impacts of illness on patients. So we taught this using a variety of teaching methods, all led by GPs, and that included things like small group taught sessions, simulation sessions, watching and debriefing recorded GP consultations, interactions directly with long-term condition patients, as well as a small number of lectures and e-learning resources. To evaluate this, we had a really useful comparator, which was Lincoln Medical School. Now, that's a geographically separate medical school from the University of Nottingham, but one that's run on the same curriculum and therefore the same learning outcomes. And at that point in time, Lincoln Medical School did not have the same issues with placement capacity. So we're able to run this module using the traditional placement-based model. We were therefore able to compare the facilitated teaching model with the traditional teaching model. And we did this by asking students to self-report their achievement of the learning outcomes, as well as their enjoyment of the attachment, and how well they felt it prepared them for the upcoming clinical phase. In addition, we also looked at the cost effectiveness of those two different teaching models. And what we found was that when we looked at the self-reported learning outcomes, the enjoyment, the preparation for the clinical phase, there was no difference across the students in the two different teaching models. And that was backed up by both our quantitative and qualitative data. The facilitated teaching model was much more cost effective than the traditional model in terms of its cost to deliver. It is perhaps just briefly worth coming back to the comparatively junior nature of these medical students. And I think there is a question of whether they perhaps realised entirely what they were missing out on in terms of less or no direct clinical time. And it's important to say that we are by no means suggesting that facilitated teaching models can ever completely substitute for placement time, especially when you think about the benefits of the entirely undifferentiated clinical care that students would get, as well as that hidden curriculum of everyday interactions with both staff and patients. But we did show here that in this exclusively facilitated teaching model, it was as effective and more cost-effective than a traditional teaching model when delivering a short primary care attachment. And so we think that this is a potentially important adjunct to clinical learning and may offer some resilience to the capacity challenges that we're all facing within medical education. Thank you for listening. If you want to read the full paper, you can find a link to it here below.